the question here, the nurse is caring for a client with a heart failure. On the assessment, the nurse note that the client is shortness of breath or dyspnea. Also, on auscultation, we found the added sound, crackles. What are the additional manifestation would the nurse expect to note in this client if excess fluid volume present? So the examine already told in this clinical scenario, patient complaint and also diagnosis is excess fluid volume overload because of heart failure. Patient has a dyspnea, crackles. What are the other signs if patient have a fluid volume overload? So when the fluid is too much in the body, patient develops some sign and symptom of fluid volume exceed, like tachycardia, tachypnea, hypertension, bounding pulse, weight gain, right? And also develop edema or jugular vein distension. So weight loss or dry skin. If the fluid is retention in the body, if fluid is excrete, weight should be increased. Weight gain, not loss. Also the flat neck and hand veins and decrease the urine output. Definitely no. Fluid volume excrete, fluid urine outflow will be increased, and also we found the veins distended, not decreased. So it is not an answer. Now increase the blood pressure, definitely hypertension. When fluid volume increase, total blood increase in the body and blood pressure increase as well, and patient develop hypertension, increase the blood pressure and increase the respiration. Number 4, weakness and decrease the central venous pressure. I said the patient develop jugular vein distension. Central venous pressure will be increased, not decreased. Answer 3 is most appropriate for here. What is their explanation? And what are the rationale and lab values? So a fluid volume excrete is also known as overhydration or fluid overload. Also occur when the fluid increase or fluid retention excrete the fluid need of the body. Assessment findings associated with the fluid volume excrete include cough, shortness of breath, added sound crackles, tachypnea, tachycardia, respiratory rate increase, pulse rate increase, right? We call bounding pulse, elevated blood pressure or hypertension, elevated central venous pressure, CVP, weight gain, edema develop, neck and hand vein distended, altered the level of consciousness, decrease the hematocrit and dry skin, flat neck, decrease the urine output is not a sign. But I said, if you see the lab below, what we can see. So if we see the lab values, we found decrease the hematocrit, decrease the serum osmolarities, decrease urine specific gravity, and it would be less than 1.01, and also decrease electrolyte blood urea nitrogen, and creatinine. So if excess fluid volume overload, we can find laboratory values like this. Now you can ask me, if my patient have fluid volume exceed, what are the nursing care? Every day we should measure the body weight. So weight daily measurement is super important. Restricted fluid and sodium is prescription. Also admit the oxygen, because patient complain the shortness of breath. Also use them diuretics, because patient develop edema, and prevent the skin breakdown. This is the nursing care every student must know. Question here, the nurse is preparing to care a client with a potassium deficit, means less than potassium normal. The nurse review the client record and determine that the client is at the risk for developing potassium deficit because of which medical condition. The normal potassium level 3.5 to 5.0. So chance of develop the hypokalemia according to this clinical scenario, right? So first of all, they said the sustained tissue damage. The major cause of hypokalemia are GI losses, diuretics, or skin loss, right? So here said require the nasogastric suctioning. So if anybody go for gastroesophageal fluid loss like vomiting, diarrhea, or sweating, loss of use of diuretics, they have a chance to develop hypokalemia, right? Hypokalemia. So here they said require nasogastric suctioning. So situation. So as I told you, vomiting and gastric suctioning, here you see the nasogastric suction, one of the cause of loss of potassium. Other cause of diarrhea or use of potassium sparing diuretics or poor intake of potassium also. So this is the important cause. What other has a history of Addison disease. We know the Cushing syndrome is directly related to develop hyponatremia, but this question about the hypokalemia. So that this client with tissue damage or Addison disease, they have a chance of develop the hyperkalemia, not hypokalemia, but this scenario hypokalemia. Uric acid level, right? Uric acid level 9.4, but normal uric acid level up to 7.5. So most accurate answer is the nasogastric suction, one of the cause of develop the hypokalemia. So rationale here, the normal serum potassium level 3.5 to 5.0 milliequivalent per liter. A Potassium deficit, also known as hypokalemia. Potassium-rich gastrointestinal fluid are lost through the gastrointestinal suction, placing the client at a risk of hypokalemia. The client with the tissue damage or Addison disease and the client with a hyperuricemia at the risk of develop hyperkalemia. So easy way to remember here, Addison means D, A-double-D-I-S-O-N, D for down. In Addison disease, everything is go down except potassium. So in case of potassium, they said in Addison disease, the patient chance of develop hyperkalemia. As I told you, in Addison disease, everything go down except potassium. In Cushing syndrome, everything is go up except potassium. What are the other cause of develop the hypokalemia? So here some causes to develop the hypokalemia, like gastrointestinal losses, like vomiting or diarrhea, or if our patient took potassium wasting drugs like diuretics, or even skin losses. So also poor intake of potassium, all can develop hypokalemia or loss of potassium. So this clinical scenario, the nurse review a client electrolyte laboratory report and note that the potassium level 2.5. So potassium level is 2.5, means it is less than normal. Patient develop hypokalemia because normal level 3.5 to 5.0 milliequivalent per liter. It is less than normal. Which pattern show nurse watch for the EKG as a result of laboratory values. So what are the EKG findings in case of hypokalemia? Means too little potassium, right? So in hypokalemia, we can see the extra U wave. It is U wave is there. Absence P wave, no. Absence P wave should be there. Inverted T wave, it is the findings. Inverted T waves. And ST segment depressed, no. ST segment should be depressed. Yeah, ST segment should be depressed too. And widening QRS complex. White QRS complex, we found hyperkalemia, not hypokalemia, right? So definitely it is the findings of hypokalemia. So same time, I want to compare and contrast the normal findings of hyperkalemia. So the normal potassium level 3.5 to 5, but here we say 2.5. So this patient is hypokalemia. In case of hypokalemia, we can say ST segment depressed, inverted T wave, because normally T wave is positive deflection, and also we can see the Q waves. On the other hand, in case of hyperkalemia, we could see wide P wave, wide QRS complex, and tall T waves. So sometimes NCLEX board asks a common question in EKG: what are the different wave represent for what? P wave represent activation of atria, right? Or atrial depolarization. And depolarization means movement of ion across the cell membrane. And QRS complex represent activation of ventricles, right? Or you can say it is the atrial repolarization and relaxation, and also simultaneous ventricular depolarization and contraction. The T wave represent ventricular repolarization and relaxation. Repolarization means return of the ion to their previous resting phases. T wave, sometimes say recovery wave. It is important for NCLEX board. What are the rationale? The normal serum potassium level, they say 3.5 to 5, and serum potassium level lower than 3.5 indicate hypokalemia, and potassium deficit is an electrolyte imbalance that can be potentially life-threatening. EKG change showing shallow, flat, or inverted T wave, ST segment depressed, and prominent U wave is a typical sign of hypokalemia, and typical sign of hyperkalemia also there. Question here: the nurse provide the instruction to a client with a low potassium level about the food that are high in potassium, and tell the client to intake of food which is contain the potassium. So select all. So what the food list contain too much potassium, right? Select all they said. So first of all, keep in mind, if your patient have a hypokalemia, educate them to take the food rich in potassium. If your patient has a hyperkalemia, educate your patient or teach your patient, limit the food high in potassium, right? So here we are going to choose what are the food contain a good source of potassium. Like here the peas, it is not, but raisin is a good source. Then potatoes is a good source. Cantaloupe is good source of potassium. Cauliflower, no, it is good source for vitamin. And also the strawberry is a very good source. Let me see what is their response. The normal potassium level 3.5 to 5 milliequivalent. Common food source of potassium include avocado, banana, cantaloupe, carrots, fish, mushroom, orange, potato, pork, beef, raisin, spinach, strawberry, tomato. So here high reaches magnesium. So up to here contain the good source of potassium. Here, but this last here, peas and cauliflower is good source of magnesium. What are the next question? Question here, the nurse is assessment a client with a suspected diagnosis of hypokalemia. Which clinical manifestation would the nurse expect to note in case of hypokalemia? The normal calcium level is 9 to 10.5, right? So everybody know the calcium is a good component for your bones and teeth formation. Calcium is a good component for nerve and muscle function. Same magnesium is the same. It help for the nerve and muscle function, is a component for bones formation. So now here we are going to speak about hypocalcemia. So basically, if the patient have a history of diarrhea or vitamin D deficiency, or if the patient have a hypoparathyroidism or pancreatitis, they have a chance to develop hypokalemia. So if the patient have hypokalemia, what are the common signs and symptoms? Like twitching here, muscle twitching. Yes, muscle twitching is a sign of hypokalemia. And patient easily develop the muscle spasm, numbness, tingling sensation in lips or finger. So I said this is the good choice. Hypoactive bowel sound. Patient develop GI upset, right? Here. And also patient develop the negative transverse sign. No, hypocalcemia patient a positive chopstick sign and positive transverse sign. It is not a choice. It is not a choice. Hypoactive deep tendon reflex. But this is that sign of hypercalcemia, not hypocalcemia. This is the choice. What is their explanation? They said the normal calcium level 9 to 10.5. A serum calcium level lower than 9 indicate hypocalcemia. The sign of hypocalcemia include paresthesia followed by numbness, hyperactive deep tendon reflex, and positive chopstick sign and positive transverse sign. So now additional sign of hypokalemia include neuromuscular excitabilities, muscle cramp, twitching, tetany, involuntary movement of muscle we call seizure, irritabilities, and anxiety, right? So again, if I say what are the signs of hyperkalemia, just compare and contrast. Hyperkalemia patient develop constipation, and NCLEX board asks decrease the deep tendon reflex, stone formation, and lethargy. So here you have to look at the sign of hypercalcemia. Hypercalcemia. But here we see the sign of hypocalcemia. The major sign, constipation developed or decrease the deep tendon reflex or hypoactive deep tendon reflex. Patient develop kidney stone or lethargies. Here, the nurse caring for a client with a hypocalcemia. Which pattern would the nurse watch for on the EKG or electrocardiogram as a result of laboratory values? Select all category. So in this question, they're asking us if patient has a hypocalcemia, what should be the EKG findings, right? So here we go. First of all, this said U wave widening, Q T wave widen. But basically hypocalcemia, we can see the inverted T wave, not widening, or prominence U wave, and also prolonged the QT intervals, prolonged QT intervals, or prolonged ST segment. Here. So prominent U wave, no. Prolonged QT intervals, this is a good choice, and also prolonged ST segment. What is their explanation? We go. So the normal serum calcium level 9 to 10.5, the serum calcium level lower than 9 indicate hypocalcemia. An EKG or electrocardiogram change that occur in the client with hypocalcemia include prolonged QT intervals, also prolonged ST segment, right? So in case of hypercalcemia, we can see wide QRS complex and tall T wave. But in case of hypocalcemia, we can see narrow QRS complex, inverted T wave, and also prolonged QT interval and prolonged ST segment. The question, the nurse reviewing the electrolyte result of a assigned client and note that the potassium level is 5.7. So these are more than normal because the normal range is 3.5 to 5.0 milliequivalent per liter. Which pattern would the nurse watch for cardiac monitoring as a result of the laboratory values? So when you read the EKG or electrocardiogram, what are the signs indicate patient develop hyperkalemia, right? So number one, ST segment depressed. It is the sign of hypokalemia, not hyper. Prominent U wave, it is not a sign. Tall peaked T wave. So tall T wave is a sign of hyperkalemia, prolonged ST segment, no, and also wide QRS complex. Wide P wave or wide QRS complex are the sign of hyperkalemia. So what is their explanation? What they said? The normal potassium level 3.5 to 5, serum potassium level greater than 5 indicate hyperkalemia. Electrocardiogram change associated with hyperkalemia include flat T P wave or wide P wave, prolonged PR interval, widening QRS complex, and dual peaked T wave, right? And ST depression or prominent U wave or inverted T wave occur hypokalemia. What next? Question here, which client is the risk for developing sodium level 130 milliequivalent? So normal range 135 to 145 milliequivalent per liter. So they said out of 4 patients, which one tends to develop 130, means hyponatremia. If you know what are the cause of hyponatremia, you can answer this question. So if the patient gastrointestinal losses, if diuretics or skin loss or edema develop, hyperglycemia or heart failure, patient has a chance of develop hyponatremia. So the client who is taking diuretics, yes, when too much fluid out from the body, diuretics can cause hyponatremia. It is good choice. The client with hyperaldosteronism, no, is not a cause to develop hyponatremia. Loss of sodium, basically, because of gastrointestinal fluid loss, like vomiting or diarrhea, or excessive sweating, or use of diuretics, or drinking too much water, or excessive IV fluid, like dextrose in water, can cause hyponatremia. Client with Cushing syndrome. Client with a Cushing syndrome develop hypernatremia, not hypo. The client who is taking corticosteroid. The person who take the corticosteroid for a long time, they chance to develop Cushing syndrome, and Cushing syndrome lead to develop hyponatremia. The person who take the steroid for a long time, chance to develop hypernatremia. So what is their explanation? The normal serum sodium level 135 to 145. The serum sodium level 130 milliequivalent indicate hyponatremia. Hyponatremia can occur in the client taking diuretics, the client taking steroid, or client with hyperaldosteronism or Cushing syndrome are risks of develop hypernatremias. Question, the nurse is caring for a client with a heart failure patient who is receiving high dose of diuretics. So high dose of diuretics can cause hyponatremia. The nurse note that the client has a flat neck pain, generalized muscle weakness. So generalized muscle weakness or fatigue, lethargic, confusion, anxiety, all of the central nervous system sign of hyponatremia, and also diminish the deep tendon reflex. So this is the prominent sign, diminish the deep tendon reflex. The nurse suspect the hyponatremia. The additional sign would the nurse expect the note in the client with hyponatremia is make it easy. So muscle twitching, muscle twitching or decrease the urine output, hyperactive bowel sound, and increase the specific gravity of urine. So in case of hyponatremia, we see the patient develop the muscle twitching, decrease the urine output, and hyperactive. So the hypoactive bowel sound is a sign of hyponatremia. What is their explanation? The normal serum potassium level 135 to 145 milliequivalent. Hyponatremia is evidenced by serum potassium level lower than 135 milliequivalent per liter. Hyperactive bowel sound. Hyperactive bowel sound indicate hyponatremia. The remaining option sign of hypernatremia. So hyperactive bowel sound are the sign of hyponatremia. So other sign of hyponatremia, basically patient develop tachycardia, hypotension, confusion, especially confusion is more common in elderly patient, or fatigue, and also nausea, vomiting, and diarrhea.